introduction, can you tell us a little bit about
Sure.
Protect Our Province BC? Sorry about that.
Sure. Do you want to do that, Jen? Oh, you're muted.
Yeah, you're muted.
I'm happy to do it.
Okay, sure. How about you do it?
Okay, sure. So Protect Our Province BC is a grassroots organization of folks that are physicians, nurses, scientists, health policy specialists, community advocates. It's quite a diverse group that's working together to advocate for evidence-based and equitable health policies in BC in order to end the pandemic. We mostly do this through briefings, blogs, videos, social media, and our website, protectbc.ca. You can find most of our information there, and we are unabashedly trying to influence the media as well to share some of the information, maybe from a little bit of a different storyline than what they might be hearing from public health or the government. I would also like to say, sorry, I'll just add that we've been collaborating with experts from across the country as well, which has also been, I guess, it's something you can see on our website. And if you look at some of our briefings or on YouTube, on our videos, you'll see that we have connected with epidemiologists, ventilation, aerosol scientists, all kinds of folks from across North America, I guess now, because we've met up with a few folks from the US as well.
Mm-hmm. You've had some really interesting guests on. I know I've really enjoyed the ones that I've been able to watch, and they're all, they're a really good length. I find, they're about an hour, I believe, and that's, it's sort of an easy chunk to bite off in the course of a day.
Great.
And so to resume sort of where we were before, we had some questions on masks, and so can you give us some information on why should we reinstate masks in schools? How important are N95s, and why do they work?
Great. Yeah, this particularly important topic today, as it was the first day back at school without masks. So happy to share what I know about masks. So we, number one, I will say a little plug for ourselves as well. Stay tuned to our website. We are updating a new blog on masks, and in particular N95s. We have a guest engineer who's written some information that we'll be sharing with everyone. But to go through it a little bit with you, so definitely, hands down, masks work. I don't think there's actually any debate about that, if there ever even was any. It does make a difference what kind of mask you use. So if we think about masks, the way they work, one is they what we call source control. So if you have germs in your body and you are breathing them out into the air, the mask will stop them from going out into the air. So you can dramatically reduce the amount of infectious particles that are floating around or that you are sending towards someone. But they also, so that in a sense, they are protecting other people that way. But the other thing they're also doing is protecting you from inhaling those infectious particles. So probably to talk about masks, we need to back up and remind everybody that COVID is spread by aerosols. These are tiny little particles that can float in the air. They can remain suspended in the air, and you get infected by breathing these infected aerosols in. And so the concept that it is spread by droplets, sort of this spittle that falls to the floor, is not accurate. And this is one of the reasons why masks are so highly effective, because it is in fact an airborne disease. Masks does make a difference which kind of mask. The CDC put out a great little graphic which we can share with you about lowering your risk. So people who reported always wearing a mask in indoor public settings were much less likely to test positive for COVID than people who didn't. And people who wore cloth masks were about 56% less likely to get COVID. People who wore surgical masks, those blue ones, were about 66% less likely to test positive for COVID. And people who wore respirators, so N95s, they were 83% lower. And this has actually been shown in quite a lot of other studies as well. The numbers are pretty close to that. Some slightly higher, some a little lower, but essentially a dramatic reduction in your likelihood of testing positive for COVID if you wear N95. And the cool thing that I learned about N95s is they're not just a sieve. It's not just a filter. They actually have an electrostatic charge that can attract some molecules. So, and it's also not just a filter trying to filter out tiny pieces. It's actually more like a sticky spider web. So things that go through actually can get stuck to the fibers. And it's great for filtering out all different sizes of molecules that are coming through the mask. So it's actually way better than just the mechanics of a filter or a sieve or a screen. It actually is more technical than that. So that's what makes N95 so much better than surgical or cloth masks.
That's interesting.
Yeah. Look, and there's a great video. We could also, I might be able to find it here, send a link to that, which it has just a little, it's like 5 or 6 minutes long, and gives basically a little bit of summary.
We can always share that, later. That would be a great follow-up.
Okay.
And I know, Jen, you have some experience in masking in your classroom as a teacher in Burnaby.
Yes, I do have experience with it. I've been wearing an N95 since September of this year in the classroom, and I actually find that it's easier to breathe through because it doesn't cling to my face the way the cloth mask did. It sits comfortably and is a lot easier to talk through, and breathe through. So for people who are worried a little bit because of, sometimes it is different to have something against your face like that. I wore the cloth mask all of last year, and when I switched to the N95, I actually found that I could breathe easier through it. So that's a good thing to note. The other good thing to note is you do get used to it over time. So I've been wearing it, like I wear it all day, except for when I'm eating. That's it. Yeah. And then with the kids, I actually had students masking at the very beginning of last year, which was September 2020, when we first came back more like full time. And we talked about how masks protect us, but how they also protect others. We talked about how in a classroom we're a community and we all care about each other. And this is something that will help prevent spread. And kids are great. When you talk to them, they rise to the occasion. And all you parents know, I have so much respect for parents, and thank you so much for giving up time in your busy day for being here. You know how your kids they get it. They can be responsible and caring and so compassionate. And so when we talked about it as a class in September 2020, even though masks weren't mandated at the time, the kids pretty much almost exclusively started wearing masks in class, and they actually wanted to. So it was a good experience for me to see, and they just accepted it and moved on. And actually, some of them even preferred wearing it outside at recess, even though I would say, when we go outside, you can take your mask off. I had a little hook on the end of the desk they could hang their mask on, but some of them chose to wear it outside too. So encouraging it in the classroom basically just comes with explaining to the kids, and I showed a couple little videos. Like there's one that's done by a 13-year-old girl, and she's awesome. She explains what the mask is for and how to make it fit, and little tricks of like tying a little knot in the end if it's too loose, and then all the don'ts. So she made a little funny part where, don't use it as a slingshot, don't wear it on top of your head, like all those kinds of things. It was perfect for the kids to see.
Cool.
And did you want to add anything, Dr. Hardie, on masks in schools?
Yeah, just a couple of things. I think Jen makes a great point about that kids can when they understand it, they know what is the right thing to do, and can often tolerate a bit of discomfort even if they have it. A lot of kids don't even notice, it's not that big of a deal, to try to protect others. And I think this probably does raise the conversation about, well, what about targeted protections? Like, well, why don't just the sickly people or people who have sickly people at home, why don't they just wear masks and all the rest of us don't have to? And it's definitely an interesting conversation. So I think the number one answer, it doesn't work very well. You actually really need to reduce the amount of the germs in the air. So the folks who aren't wearing masks are still spreading the virus into the air. And now if you have high rates of virus in the air because the air is not the room is not well ventilated, there's no other filtration, there's a lot of people in the room, there are a lot of sick people in the community who are then in the room breathing the air. Suddenly, all of these factors start to really add up, making it a very unsafe place to be breathing air. And so now your mask alone is not enough. And especially if you're there all day long, you can maybe sometimes make it better if you're in a place for a short period of time, but you're there all day at school. So it does leave these folks very, very much at risk. And so the only way really is with the two-way masking, where everybody is wearing masks. There was a great study out of Duke that showed that schools that had mandatory masking versus schools that had voluntary masking, there was an 83% reduction in the rates of COVID in the schools that had mandatory masking. So, and there's more than just the one study. There are quite a few studies showing that in the real world, it actually works. Even if people do it less than perfectly, it still does make a dramatic reduction in the rates of COVID in those schools.
Yeah, that's a big reduction, 83%, I think you said. Wow.
Yeah.
Yeah. I know that I have two kids in elementary, and we've been wearing the KN95s all this year, and I find it's a lot easier to get them into the masks. We kind of have a system of like a mask for every day, hung up at home, and they just grab it before they go to school, and they're comfortable to wear. And yeah, it's been a success for us, at least.
And that's another good point that you bring up in terms of being able to reuse the mask. So in terms of cost, because I know, economically they are a little bit more costly than the surgical masks, but I did a lot of research online, and I know Dr. Hardie can probably speak to it too, but I've been rotating my masks. I wear it all day, and then I put it in a paper bag, and I have a different mask for each day of the week, Monday, Tuesday, Wednesday, etc. And then the next week I can re-wear it, and I do it for about 4 weeks. So then I can make a box of 20 masks last for a couple of months that way.
Absolutely. And I looked into that quite a bit too. The manufacturers often say they're only good for 8 hours of wear. But a lot of scientists have been studying and have been saying that at least up to 40 hours of wear, no problem. And even probably longer. A lot of folks are saying they probably actually continue to filter for as long as it stays intact and the loops haven't fallen off and it isn't gross and grimy. It probably breaks and gets grungy before it stops actually working. But I'm also an employer, so I will tell you, I had to kind of think twice. Well, what am I going to say as an employer? What am I going to tell my staff that are wearing KN95s? How long, or N95s? How long can they wear them? And so at first we were saying just the one day. That's what the manufacturer says. And then 3M came out with a statement saying, yeah, your masks are probably good for a whole lot longer. So we're doing basically what Jen's doing, and I wear my masks until they fall apart. And at work, I'm telling people at least wear them for 40 hours and probably longer if they still look good. So I think there's more than enough science. If you follow the Mask Nerd, if you Google Mask Nerd, he has quite a lot of information, has done a ton of testing on masks. I think it's pretty safe to say they work, and they work better than other masks even over time. Compared to, say, a cloth mask that you washed every day. Your N95 that you've been wearing for, alternating for a couple of weeks is still far superior.
I even find with just the fit that it's superior because, you know, I find that I'm getting a much better seal. I'm not getting as much fogging in my glasses. I feel it's fitting me under my chin, you know, whereas with cloth masks, I never really got that good of a fit. So yeah, that's great. I hadn't heard about the mask nerds, so I'm definitely going to have to check that
Check
out.
them out.
Yeah. And then we also had some questions about indoor air quality. I know that's been a big topic in schools. I think it was 3 million that was said to have been spent on improving the ventilation and filtration in schools. So some of the questions were is ventilation filtration in classrooms an important protection? And how do carbon dioxide monitors work? And how can they be used in the classroom? Maybe we'll just start with those and then move on to the others after.
Sure. So yeah, ventilation and filtration is critically important. It's probably one of the most important things. If we were to do anything to improve and reduce rates, if we had regulations, legislation, and then support, money, resources to have appropriate ventilation for the COVID pandemic, it would make a huge difference. So because it's airborne, again, this is such a critical piece. Once we recognize how it spreads, then we now are empowered to know how to stop the spread. So not having it in the air floating around us is a critical way. So I don't know if you talk to ventilation experts, ventilation engineers, they, you know, have been shouting this since March 2020. We should all be having improvements to our ventilation. There are guidelines from ASHRAE, which is the American, Society of Heating, Refrigeration and Air Conditioning, I think is what it actually stands for, but it's ASHRAE. And they do, and in BC, we do use those guidelines, but unfortunately we're using guidelines from 1989. Things have changed a lot in the world of ventilation for a lot of reasons, and they changed dramatically in 2000 for the pandemic. So the ASHRAE, which is the American Society of Heating, Refrigeration and Air Conditioning Engineers, thank you, does have pandemic guidelines that were updated specifically for the pandemic, because before it was really just about comfort and a little bit about health, but now it's so much more about health, which changes the guidelines. So you need to have a lot of air being exchanged. You need to have your room refreshing with fresh air on a very frequent basis. And the number of so-called exchanges per hour makes a dramatic change in the risk of transmission. So the more exchanges per hour you can get, the lower the rate of transmission. I mean, up to a point, there's clearly a ceiling, but it definitely is a linear kind of a scale. So you need fresh air coming in. If you don't have a good ventilation system to do that, then you hopefully can open windows to get fresh air in. Then there's the filtration part, which is what kind of filter the fresh air is going through, as it, or the room, any recirculated air, I should say, is going through. Again, it's sort of a little bit like that fabulous filter we have for our face, but it's for all the air inside the building. And there are some guidelines on that, a MERV 13 filter or better, but it is a bit complicated. There are ventilation engineers for a reason, because it does really depend on a lot of things like humidity and the size of the building and the capacity to move air through. So it's not sometimes as simple as sliding out a filter and sliding a new one in, and sometimes it is, but definitely our schools should be focusing very heavily on ventilation filtration. And the way CO2 monitors come in is that they are a way of checking to see if the ventilation is doing what we believe it's doing. So if you've got a CO2 monitor, which is relatively inexpensive, it can measure the amount of CO2 in the room, which is essentially mostly from people breathing. So the more CO2 we're expelling into the air, if it's not being refreshed, then we're going to see the amount of it building up. So outside, it's around 450 or so outdoors. Indoors, if it's up to around 800, that's considered okay. And above that, you should be starting to take action to open windows or check your ventilation system to be bringing in more fresh air, because then it's a sign that, yeah, essentially you've got a lot of stale air. There was we also did a briefing on that called Name It to Tame It. So if you want to watch our video, we have some experts in ventilation and also aerosols who talk on that one and one of our earlier briefings as well. So I think it's a pretty important part. A really cool new study that just came out in Italy. They found that they compared classrooms with improved ventilation versus classrooms without, and it was a fairly big study. I think there were 10,000 classrooms altogether over several hundred schools. And they found that the risk of COVID transmission was reduced by 80% in classes that had ventilation. There's also some really old studies going back 20 years that show good ventilation actually is associated with cutting sick days in half in all workplaces. And as well, other studies on schools long ago showing that kids actually feel better, focus better, have less headaches. So not just about COVID, having clean air is actually, who knew, really important for our health and well-being. Kind of funny.
Clean our water. What about cleaning our air?
Really, it does feel like that. Like it's hard to believe there was a time that people didn't think about cleaning the water, and we are at that place right now about air. Really, we should be cleaning the air.
And
go ahead.
Go ahead, Jen. I was about to ask you, I think you've used a CO2 monitor in your classroom, have you?
I have, yes. So here is what it looks like. I will hold it up to the screen. This is called an AirNet 4, and it's a little portable carbon dioxide monitor. And you'll see the number on the screen. It says 521. It also registers the temperature and the humidity in the room, but really the important thing is the carbon dioxide reading. So the reading in my house right now is pretty good. I do have the windows open at this point. When I've been using it in the classroom, when I'm in there by myself, it'll be in the 550, 570 range. But then once students come in, it does go up because of course you've got, more people in there breathing out air. So then it goes up to around 650, even up to 700. And I kind of know, like I keep my windows open. So number one, right from the beginning of the first time we went back into classes in June in 2020, I kept the windows open the whole time. And that was just for that partial reopening that we did. And then in September 2020, when we did the full reopening, windows were open all the time, and I would have a fan pointing out the door so that the air would be hopefully drawn, like pushed out the door and coming in from the windows on the opposite side. Yeah, trying to get that 6 air changes per hour that they were recommending. Anyhow, with the carbon dioxide monitor and me using the windows still open, the reading would go up to around 700, 750 at times, depending on the wind, how much breeze there is that day. Other days, if it's really breezy, it'll go down to 600 with the kids there. It has gone above 800. And at that point, I know that, okay, either we need to leave the room and go outside for 15 minutes, or I need to add a second fan because the air is super stale that day. So the thing that's nice about the carbon dioxide monitor is it gives you data in real time so that when I look at it, I can make changes accordingly. Add that fan on or make sure that we have a bit of a break. So I think it's highly recommended. They cost about $300. Now you can buy them for about $300. There's other ones that are on the market that are on like they sell them for about $200. When I did my research on it, it was important to get one with an NDIR. What do you call it? I can't remember. Filament. I think it's a filament. Yeah, inside. So that's what the experts are recommending, and they range in cost from a couple hundred to 300.
So as a parent, when I hear about, windows open and a fan pulling air in. And my first thought is, gosh, are you guys cold in your classroom? How does it feel?
That's an excellent question. It does get cold at times. I do have to say it does, and especially in the winter time, you've got the windows open. Sometimes we have our jackets on, and the odd time we've had to wear, those little gloves, but most of the time, luckily, it hasn't gotten that cold. But there have been a few days where, it would get down to about 12 degrees. 15 sometimes. At 15, you're feeling chilly. 12 is quite cold. And luckily, that's only a few days. But this is where, with extra filtration, you wouldn't need to have your windows quite so wide open.
And so what kind of, are you talking about HEPA filtration then?
Yes, I'm talking about a HEPA filtration unit. Maybe before we start talking about that, would Dr. Hardie want to explain a bit more about HEPA filtration units?
Well, sure. I think it's really important to point out, Jen, that you wouldn't need to be wearing your little gloves in a cold class if we had adequate ventilation and filtration for the building. I mean, no engineers are advocating that everyone just open their windows all the time, all winter long. And there are some communities that just really honestly couldn't. And especially in really dry places, because it actually drives the humidity down, which is another thing that increases your risk. So you really need well-engineered ventilation filtration systems for the building. Opening our windows and putting in fans, these are kind of stopgap measures to keep everyone safe, and they're important and they're doable, right? And there's something that are within your control that you can do if your school doesn't have the appropriate ventilation and filtration. And I think portable HEPA filters are another version of that. Essentially, if you don't have adequate ventilation filtration, at least you can bring a portable filter to the room where you are, which essentially also is filtering the air to filter out. It's sort of similar concept to the filters on our face, filtering out the air in the room. And so they are potentially a somewhat affordable, depending, especially if you do the DIY Corsi Rosenthal box that you can build yourself, or appropriately sized HEPA filters that you can bring into the room where you are. They can really dramatically reduce the amount of infectious particles in the air. We don't really have a way of monitoring that to know. You really have to trust the unit. So the science is really making sure that the units or the number of units you have are sized appropriately for your space. And that they are true HEPA filters, and that they don't have any other chemicals or ionizers or anything else added to them, which is the safety of those is a little bit uncertain. You really just want a true HEPA filter appropriately sized for your space.
Sorry, go ahead, Jen.
That's okay. So I was going to say that I actually do have a HEPA filtration unit for my space that Burnaby bought. So the district bought 350 HEPA filtration units for the classrooms that don't have mechanical ventilation. And my building happens to be fairly old, does not have mechanical ventilation. So we qualified. And so I've got one in my room. It's a Jade 2.0 is what it's called. And when I did the research on the numbers, like on how much capacity it had for my size of room, so I measured my room cubic meters of the space, and checked the numbers, and it would do about, when you've got it on high, it would do about 2 air changes per hour. When you have it on turbo, it's about 2.5 air changes per hour. And then of course there's the lower levels as well, which would, but those are the 2 highest levels, which is from following some of the aerosol engineers online. They were saying that, that's probably what you would get from one of these big sized HEPA units for a classroom, that some classrooms would need 2 HEPA units, like one in the front and one in the back. Or you do what I do, which is use the HEPA unit and have the windows open at the same time. But at least it's cleaning the air closer to the source, which is where we are breathing, the kids and I. So that's something that's handy to know. Now, some people, worry about the noise that the HEPA, it does have background noise, especially when you're running it on high or on turbo, the way I have it. And this is where this little device comes in handy. So I'll show you. I have I asked my district if they could buy one of these way back in September 2020 when we came back for the full-time teaching. It is a little wireless microphone. So I have here, you can sort of see here, there's the microphone thing, and that fits over my head. And I love the fact that it's wireless because I can put the little speaker at the back of the room and the kids can hear me. So when I first ordered, asked the district to buy it, and they did, the reason why I had it was because I was trying to speak through a cloth mask. And it was harder for the kids to hear me, and especially if, they can't see my mouth. So it's more important that they could hear what I had to say. And so this is way before the HEPA filtration was bought. I had this, and the nice thing about this is they're only about $100, and it wirelessly connects, and I just turn it on and off right here. But I can take it to the gym. So I've been using it when I go teach in gym. It's so much easier than trying to shout. And when I do outdoor teaching. So when I take the kids outside and we're doing a lesson, I take this out with me and the kids can hear me so much better. So I've even taken it on, field trips to the park, that kind of thing. So then when the HEPA unit arrived, it became even more important that the kids could hear me over the background noise of the HEPA unit. And so this is indispensable, but it is fairly reasonably priced, $100. And, it's just, you recharge it every night and away I go. Yeah. Just some handy tips and tricks for teaching in a classroom.
Those are actually, I moved from Ontario about 10 years ago, and those are actually considered a standard accessibility tool for all classrooms in Ontario, that you have to have access to them for kids who are harder of hearing, because you can't have them all sitting in the front row. And so they're just a standard tool. So it's really kind of interesting how it's becoming an accessibility tool in a different way. And it makes sense that having access to them would be huge. Even just as you said, not shouting in gym all the time. Brilliant.
Imagine that saves your voice over a day full of talking.
Oh, definitely.
We had one other question that I know that we've heard from people, concerns over whether HEPA units spread virus around when they blow the air, or even just fans in classrooms. Did either?
Yeah. I'm definitely not a ventilation expert, but my understanding is generally the answer to that is mostly no, certainly not with a filter. Because that's the whole point. You have to draw air through it in order to filter the air. So if the air is not moving, you need to do that. But because it is filtering, it's not actually spreading. There's a theoretical risk if the filter was so full that it was no longer filtering. But again, following the recommendations for changing the filter on a regular basis, and it's long. A lot of the filters in especially portable units can last a very long time. Depending on the unit, it's like a year for a lot of them, but it does kind of depend. Short answer to that is no. The other thing I think though we worry about fans in general, again, is that you really do, if it's causing the air to be exchanged, the amount of fresh air actually offsets any movement of air. And the other thing is it's in the air. So if it's in the air, if it's in this side of the air or over on that side of the air, it's still all in the air. The only places that it really could go where you're not breathing it is perhaps in buildings where it's really big and it's allowing it to disperse a little bit more, but the flow is really not going to change all that much. Having said that, there were lots of cases of restaurants where there was some laminar flow of air where especially with plexiglass, it was directing air towards people. So they weren't thinking they were, in the direct path of someone exhaling, and it turned out that they were. But I think still generally the whole concept of having fresh air and filtering the air is still the answer to that, as opposed to not having air move at all. So that was the best I could find on that, Jen. Maybe you know a bit more.
Yeah, I can say that the unit that I have, and I think from reading some of the aerosol engineers online, that a lot of the units they're making nowadays are trying to take that into account. So the unit that I have sucks in air, the intake is at the bottom. So it goes like this, and then it goes through the machine and out the top. And so the main airflow is going this direction, straight up, and then it can disperse kind of that way. So it's kind of sucking in, hopefully, the dirtier air from the below and then blowing out the clean air at the top. So it's not like it's directing any airflow the way we think of a regular fan. It just blows it straight up.
It's not going sideways.
Yeah.
Right. Okay.
Yeah. And when I use a fan in the classroom, I never blow it across the students, you know, reading through the guidance, of course. So it's always just pointed out the door, or they say out a window. The way my windows are, though, you couldn't get a fan up there. So for me, it's out the door. So then it's drawing the fresh air through the windows.
Okay. We had a question about Corsi Rosenthal boxes, and whether you've read how effective they are, or if they're effective, and what you'd recommend seeing as some districts, and I believe VSB falls into this, although DPAC could speak a little clearer on this. If schools, I think VSB has said that schools can't accept donated Corsi Rosenthal boxes due to liability.
Yeah, I dug around a little bit on them. I think the liability issue is because it's not tested in that format, and you know, especially around maybe the electronics, for example. I think though the question of their filtering capacity and whether they work well as a filter has been very well established by quite a few rigorous studies actually on the boxes and various designs. And so I think in terms of does it filter the air well, I think that answer is a definite yes, and there are quite a few studies you can find online. I can't really talk though about the safety of the fan, you know, being plugged in with filters attached to it, but so far reading actually the Corsi and Rosenthal studies themselves, they say that it is very safe and there have been no safety issues regarding the electronics around that. So I don't know if that's good enough for schools, but I certainly would have no problem having them in my clinic or in my home. I from my own research and reading online and seeing how well they've been studied, and then the thousands, tens of thousands, maybe it's even hundreds of thousands that have been used now all around the world, I really am not concerned.
It's actually come to my attention that perhaps not everybody knows what a Corsi Rosenthal box is. So anybody who doesn't know, it's a box fan. And then it's been designed by some ventilation experts where they take panels of either usually MERV 13 or HEPA filters and create a box, usually the four sides and then the underside, with the fan on top, and it's all duct taped together. And it's something that can be made by parents and students to create a filtration unit that has been used in a number of schools and other venues. And I know a parent in Coquitlam who created a few for his classroom, and they were used successfully. Oh, thanks, Karen, for posting that. I think we were going to move on to testing. We had some questions on testing, the different variants, and specifically the most recent variant, BA2. So one of the questions was, what differences are we seeing between strains, testing being less effective with the different strains, and post-COVID people testing negative with rats? or rapid antigen tests, but positive with BCRs. Are rapid tests working as well with current strains? And if people are testing negative with a rat but are feeling unwell, what's the best advice? I know that that's something I've run into quite a bit.
Yeah, there definitely has been a change with Omicron, for sure, in terms of testing. And so maybe just backing up a little bit and reminding ourselves that the PCR test is the one that's done at the lab. It can be a saliva or a nasopharyngeal swab. Those tests are almost impossible to get now. They are really reserved only for people who might be eligible for treatment. So it's a really small group of people who can get a PCR test. And that is the test that answers the question, do I have COVID? And it can pick up really tiny bits of COVID, and it might even remain positive long after you're not contagious anymore. But it is the so-called gold standard in terms of a test that we use for a diagnosis. The rapid antigen test, the RAT test, is the one that most people are using now because it's the only one you can get, and now you can get it, which is even cooler, or mostly get it. So if folks aren't aware, anyone 18 and older can get 5 tests every 28 days from the pharmacy. And I would strongly recommend that everybody put it on their calendar and get 5 more every 28 days, even if you don't need them, because you're going to need them at some point. So it's not hoarding, just get them, because they're going to be very valuable tools. If you don't need them right now, you will very shortly. And I know, again, I'm not so familiar with exactly what's happening with schools, but they were sending some out with schools as well. So these tests answer the question, am I contagious? So sometimes you have COVID and you maybe are past the contagious phase and you had COVID. This test is not going to be as good at finding that. And also sometimes you have COVID and you're not yet shedding enough of the virus to be contagious. So again, it's not going to tell you that you have COVID in that circumstance. So it can't answer the question as well, do I have COVID? But it answers the question, am I contagious? Am I infectious? And the biggest thing that changed with Omicron, and my understanding is both BA1 and BA2 variants, is that people were starting to show symptoms for 2 or 3 days before they started to test positive on the rapid antigen test. So what we're seeing is a lot of folks not testing positive till day 3. And in fact, I think the peak is around day 5, 6. So it's not uncommon for people to be having symptoms, have a negative rat. And then the problem is people are doing the test at day 3 and they're going, oh, good, it's not COVID, it must be a cold. And then carrying on as though they don't have COVID. And that is not what I would recommend. If you have symptoms and you test negative on day 1, 2, 3, and you're still sick, day 4 or 5, and you're still sick, you should probably be testing every day. And the problem, of course, is you may not have enough tests around to really be able to test you and the number of people around you who need it. But ideally every day, or perhaps every other day. One of the things we're seeing with Omicron is that the switch from being symptomatic and negative test and then a positive test is shorter, like within hours. You could test yourself in the morning and be negative. You test yourself in the afternoon and you're positive, which was not the case with Delta and previous variants. So a delay to positive test, a quicker change in the test from when you last tested. In terms of accuracy, I think my understanding is it is as accurate if you take into consideration that it's testing for infectiousness, but it may be that we're not picking up as many people who had COVID because they aren't shedding as many viral particles and they are having some symptoms. I struggle with calling that a false negative because that's not what this test was ever designed to do. I will say it is possible to have COVID and have a negative rat and then often a positive PCR. The opposite is also possible to happen, but we're not going to know anymore anyway because you can't get a PCR, so I'm not sure it's really worth talking about too much. So essentially, if you have a negative rat and you've got symptoms, assume it's COVID, because right now there's way more COVID out there than any other virus. There's almost no influenza. If you have muscle aches and fevers, that's not a cold. So if you have anything that feels flu-like, it is most certainly COVID. And there's no reason for you to suspect it's anything else. And so you should act like it is. So isolating yourself, don't go to work, keep testing yourself every day or every other day. And then if you have no symptoms and negative rats, then I think you can be pretty safe to say that you're not spreading it to anyone at that point. I can tell you in my office, we do screening. So we test asymptomatic people, which is a whole different story. And in that, we've definitely had folks who were positive and they had no symptoms, or symptoms that they ignored because they didn't think it was anything, a little tickle in their throat, and they tested positive. So, you know, we've kept people out of a dangerous place where they could have infected other really quite sick people in family practice. We've also had folks, because we've had access to tests before other people did, we've had them keep testing themselves. And we were like, you're not coming back to this office for 7 days and negative COVID. And we've had folks up to 10 days. So, and they were feeling fine, but they were still positive. So, COVID hasn't changed. You can still be giving COVID, a week, 10 days later. It's just that our policies have changed. But you can keep spreading COVID 10, even 14 days potentially later. But the good news is we now have tests that can give us a little more information that can maybe help us a little bit deciding how we should act.
I find it really confusing with the different policies between provinces. I know, my husband was talking to his sister in Quebec, and they, after 5 days, they can go back to school, no problem, regardless of whether they have any symptoms or not. And, here, I'm not even sure what the policy is here, because I find the information isn't available. Or maybe I'm not.
Yeah, no, it's not easy to find, and it's not clear, and it's not always logical. You can't just rely on logic to remember it. So that's why you have to keep going back and reading it, because it doesn't actually make sense. Because a lot of it is actually based on keeping people at work, keeping people in school, keeping the economy going. It's not about infectious disease control. It's not about reducing transmission to the maximum amount. It's about not overwhelming hospitals. So this is a funny thing that we can't intuit, right? It's not the same target maybe that you have and that I have. So if I don't want transmission, I probably shouldn't be going back till at least 7 days would be the earliest, probably ideally even 10. But if I want to go back earlier, I should be testing to make sure that I'm negative. But in BC, you're allowed to go back to school once you're no longer sick. So it's just basically by how you feel. Which of course will lead to more COVID being spread.
Yeah, especially if you're not having as many symptoms, but are still, if you had taken a rat, would still be showing up as infectious.
So up to 50% of COVID transmission is by people who have no symptoms. So there's some people who never get symptoms and spread COVID, and there's some people who are spreading it, but they don't have symptoms yet. So at least half of the cases are spread that way.
We just had a question come in. I'm just reading it right now. Given that BA2 is 60% of BC COVID cases currently, and that BA2 is 30% more transmissible than BA1, should my child be wearing a mask outdoors during recesses, or is the risk so low outdoors that it is not necessary?
Yeah, I think the risk outdoors is really low. My only issue with kids at recess is they sometimes sit together with their heads really close and are breathing on each other pretty hard, So, I mean, the risks are low, but the transmission in the community is not. It's medium to high. But generally speaking, our risks outdoors are lower because of there's so much space for that virus to go. But it's not impossible to spread it outdoors when you could potentially be really quite close to someone. I don't know. Maybe I'm not the person to ask that question. I have a hard time telling people to wear masks outdoors, but I have personally worn masks outdoors. So, like at Christmas time and over the late December, I would go to Mount Seymour snowboarding. It's a super small hill. There's hardly anybody there. but there was just no way I was standing in that line knowing that our Omicron peak was just off the charts. How many people standing there I know are spreading COVID. Personally, I wore a mask the whole time I was there. Our rates are not at that now. They're down about what the rates were early-ish December, but they're not low to baseline like they were in the summer. So that's why they're still in that sort of medium high category.
And I guess that also leads into, so what do we know about BA2? Can you explain a little bit about the variants?
So mostly what we know is that it's in terms of most things, it's very similar to BA1 in terms of symptoms. It is probably 30 to some people are saying maybe 50% more transmissible, mostly again from immune escape. So the big issue here is that 3 doses of vaccine makes a huge difference in terms of reducing transmission. 2 doses reduces your likelihood of being hospitalized or dying from it, but it does not reduce your risk of transmitting it very much compared to an unvaccinated person. So it is really quite important to be having 3 doses for BA2, and it was important for BA1. Interestingly, with the increased rates of transmission in a few countries, we're seeing another wave definitely starting, and probably fueled by BA2 being that much more contagious, and also reinfection rates are higher, which I think is the main issue here. Is it used to be that you were very likely to be reinfected with the same variant, especially Delta and before. Omicron reinfection rates are significant. BA2 you can get even if you had BA1, so you can get Omicron twice. And Ontario actually now has on their situation reports, your likelihood of reinfection is one of the metrics, and so does the UK. I have it on their sort of dashboard. And I just checked today, and Ontario is stating that the risk of reinfection is high, and their certainty about that data is good. So yeah, there's just no point in trying to get COVID to prevent COVID. It just means you're going to get COVID, and you can get COVID again.
Okay. Wow.
Sorry to be a bummer.
No, that's okay. I mean, it's better to have this knowledge and operate from a place of knowing what you're up against, rather than, keeping your eyes closed and not listening. So we were going to talk about vaccinations. This is a great leading into that. So where is BC and Vancouver in the vaccination rates and kids? And how well are teens who are fully vaccinated compared with kids who are, I guess you've already talked about that, but being single or double or 0 vaccinations.
Yeah, well, and it's interesting when you look at the rate. So BC is doing terrible. If you look at it across the country, we're the 2nd lowest rates of vaccinations in children, but Vancouver actually has some of the highest rates of child vaccines in BC. I think it was quite significant number got their first dose. I think it was 70% maybe in coastal. It was shocking, but overall, only 56% of kids have had 1 dose at ages 5 to 11. Only 36% have had 2 doses. And that's quite a difference compared to the 12 to 17s, where 85% have had 2 doses, but only 33 have had 3 doses. So it's quite unfortunate that people didn't get the message that the 3rd dose reduces transmission for Omicron. The message we got is 2 doses is great. It prevents you from getting really sick. So again, it really depends what your target is. Are you trying to prevent transmission? Are you trying to keep hospitals open? So again, our messaging that we get from public health is 2 doses is enough to keep hospitals open. But if you actually want to reduce transmission, you need 3 doses. And I see someone said Vancouver or coastal health. I think it was actually Vancouver was what I was reading. I don't know. I could probably go on they do have the rates by health authority online so that you can check them. Yeah, Vancouver was 70% first dose. So yeah, overall, we're not doing great, and we're definitely not doing great in getting the teens third doses. And maybe again, if the information was a little more clear that you can get reinfected, that 3 doses is dramatically better than 2 to protect you from transmission, we might see potentially better uptake.
Yeah, that's a good point about education. And pediatric vaccine efficacy, is it waning sooner? And what conversations are happening in the medical community about ensuring their child has this mode of protection?
Yeah, I didn't come across anything that was convincing that it was waning sooner than it is in adults. But I'm happy to be corrected if someone has seen those studies, because I'm assuming that was like a leading question, that there must be something, but I didn't come across that. So, and it is actually tricky business looking at waning immunity. It's partly based on how many people who were vaccinated get infected and hospitalized, right? So there's some ways by measuring antibodies, but also more accurately, it's really about how many people are getting sick despite being vaccinated. And mostly they're looking at hospitalizations and deaths. And of course, we have very few absolute numbers of deaths for children, which is as it should be and is a good thing. So it can be a little bit trickier to collect that data. And also we haven't been vaccinating them as long. But my understanding is that the vaccine is waning as it is in adults, which is probably anywhere from 2 to 3 months after your vaccine, your efficacy definitely starts to drop off. And by 6 months, it's pretty much gone. So we really should probably be having easier access to boosters a lot sooner. And people 60 and over should probably really be considering 3 doses as their primary series. 2 doses is really not adequate, certainly 70 and over. So you should really be considering you need 3 doses to start, and then boosters after that.
And there's talk about a 4th dose, is there not?
Yeah.
No.
Yeah, and certainly for folks who don't mount a very good immune response to vaccines and who are at very high risk of illness from COVID, that group should be getting 4th doses probably now, or maybe even a few months ago. And I think Ontario has already started to offer 4th doses. There's talk of 4th doses here, but I haven't actually seen anything, and it will likely be the CEV group, the clinically extremely vulnerable, since that's what we've done in the past, which isn't ideal by far, but absolutely, if it's 3 to 4 months out and I could get a 4th dose, I'd be getting it myself. But that's where we're at in BC right now.
Okay. And so if someone in your household comes down with COVID, what actions can you take to prevent it spreading to the rest of the family?
So essentially, isolating is pretty important. Now, I guess before I go on to say too much about what to do, this is obviously really going to depend on your ability to do these things. So socioeconomic is going to be huge. Like, do you have a room where a person could go? Can people, how many people are sleeping in a room? Is there a space for that? How many people are sharing bathrooms? So, I mean, it's really hugely dependent on your home and the space in it and your ability to access resources. In an ideal world, the person who is sick would stay in a separate room. You would keep the window open so that air was definitely all the windows open, actually. And if you have any kind of fans, that can actually help to most people don't have ventilation systems, but even if you have exhaust fans, it actually, if you have windows open, it'll help. It's sort of that cross breeze idea that Jen was doing for her classroom. Everybody should be wearing N95, or at least the very best mask you possibly can. And if possible, that person should really not be sharing any of the house. If they do go into another room in the house, you'd want to not go in that same room for even probably a couple of hours afterwards. Again, recognizing that the germ can kind of linger in the air. So just because they've left the room doesn't make the room safe. If they were wearing a mask, it makes it safer. And if you're wearing a mask, it makes it safer. The windows are open. And then portable HEPA filters. You could have filters in the rooms where people are. It's probably not affordable to have them in all of your rooms, but the room where you're staying, if you have your filter with you, it cleans the air in that room. Those would be ideally the things that you would do, but of course not everybody can. It's very hard with small children too. Like essentially what a lot of people that I know do, like almost all the docs in my office have little kids. Pretty much one parent becomes like the sacrifice parent to take care of the little kid, because you can't not be close to a sick toddler or an infant. So, but they try to limit the exposure to the rest of the family by having one parent become that main caregiver.
Yeah, no, it's definitely difficult when, you know, depending on your space and the age of your kids. Yeah. It's good to know that it is possible that we can use these tools though to limit that possibility of infection to the rest of the family.
Oh, it works absolutely. I know. So once everyone went, daycares and schools and everything opened after the last wave, it obliterated my office. Every doctor with kids, within a week to 2 weeks, their kids from school or daycare brought home COVID, but they did not have 100% transmission in their homes. They definitely were able to contain it. In some homes they did, there's no question, but you don't, just because COVID's in your house does not mean you're going to get COVID. It's absolutely worth trying to prevent the spread.
Okay, thank you. So long COVID in kids, what do we know about this currently? Does long COVID only affect those with comorbidities, or is it something that can affect all kids?
Anybody can get long COVID, and we don't know what makes a person end up with long COVID versus another person who doesn't. So it's not predictable that way. They're working to try to figure out maybe what some of those risks are, but it's certainly right now it could be anybody, which is also the reason why it makes sense to reduce transmission, not just keep our hospitals from falling apart, but because we don't know who is going to get long COVID. And the best estimates are about 10% of children who've had COVID have long COVID. And by long COVID, we mean has symptoms lasting 12 weeks or more. And a lot of the more common symptoms are really quite severe for a lot of kids, especially a lot of memory problems, foggy thinking, inability to focus, a lot of breathlessness, shortness of breath, fatigue, a lot of kids just really not having energy to do much, walking around even. So it can be quite profound for some kids, and it can last much longer than 12 weeks in some cases. It's being studied best in the UK, as far as I can see. We don't have a lot of studies or even resources in Canada, and very little in British Columbia. So we do have to look elsewhere for a lot of the data. But it is worrisome to see that it affects kids probably at similar rates to what we've been seeing in adults. Actually, around that 10% is probably the most accurate number.
That's a lot higher of a number than I've heard in the past. So that's interesting that I think it feels like we're still learning so much about it, that it's, you're seeing different stats and sometimes it's hard to know what to follow.
Yeah, and I will say that it's even emerging to create a really clear definition of long COVID, so that we're always talking about the same thing. So a lot of the studies that came out that gave lower rates of long COVID were actually not truly long COVID studies. They were studying rates of particular symptoms, and not even as a cluster of symptoms. And so it's really not an effective way to be tracking actual long COVID. And so it was giving some underestimates essentially of actual cases of long COVID. But you can also see how tricky it is for to track long COVID, because it's not like there's a blood test for it or a swab test for it, right? It's a collection of symptoms that's being refined as we learn more about it. And also in kids, we're seeing so many more, because so many more numbers of kids were infected with Omicron. So the actual data is really from this last wave, which was November, December, early January. And so we are starting to see those numbers and learning a lot more about long COVID in kids because of the mass numbers of kids that were infected in the most recent wave.
And are we seeing more long COVID as kids get reinfected, I would guess?
I don't know, and I don't know that anybody knows the answer to that, and that is one of the things that people are trying to sort out. Are you more at risk for long COVID the more times you're infected? Are you less at risk the more times you're infected? Like, I don't know that we really actually have solid answers to that. And I think this is a really important point. Anytime we say we don't know, then we should be applying the precautionary principle. If we don't know if multiple cases of COVID make you more at risk for long COVID, we should be reducing transmission of COVID, right? We should be changing the goalposts, not are our hospitals overwhelmed, right? So, and I think in particular, talking about children who are infected, it was something that could potentially last months or years. I think this is a classic time where the precautionary principle just makes the absolute most sense to me. Until we can know, we should be doing everything we can to be protecting children from getting COVID, even if the majority of them have a short illness and are mostly fine and don't end up dying and aren't in hospital. Because of this risk, we should be being much more careful. We're far more careful with chickenpox than we are with COVID. And the rates of long-term complications from chickenpox are far, far less.
Wow. I am just taking a moment and looking at the time and looking at some of our questions. Is it okay if we go a little bit over time, Karen? And Dr. Hardie and Jen, do you have a few extra, maybe 10 or 15 minutes to stay just to answer the, okay, sure. Great. Awesome, thank you. So we had some questions about Miss C, about, is that how we pronounce it? I've always said that, I don't even know if it's right.
Yep.
And what is it? How does it present? How common is the need to hospitalize a child with Miss C? And how lasting are those effects too from Miss C?
Yeah, so Miss C is actually really, thankfully, quite rare. The rates are around 300 per million. So we don't see it all that much. And the vaccine is highly effective in preventing Miss C as well, probably 90% effective. So, but it is a very severe illness. Almost everyone with Miss C is hospitalized. I understand there have been 0 deaths in BC from Miss C. And I don't know the total number. I was trying to look it up today. It wasn't so easy to find. I found that there have been 270 cases in all of Canada so far, or up to the last count that I could find, which was November. So maybe somebody's better at sleuthing than I am. They don't make it easy to find Miss C on the dashboard, I can tell you that, from the BC CDC. You have to go digging in the situation reports, and you have to open every single one of those files to try to find them. So it stands for multi-system inflammatory syndrome in children. And it, just as it sounds, it is an inflammatory response, usually that comes on after a case of COVID, relatively soon, within weeks of a case of COVID. Kids usually have a high fever. They may have vomiting, diarrhea, abdominal pain, rashes, but the sort of shock-like syndrome with essentially affecting their heart and blood vessels is really quite dramatic. It's not the kind of thing you would wonder, does my kid have a Miss C? If they do, you likely are already in the emergency department. Kids look really, really ill, very lethargic. It's not something most people would miss. So it's serious. Children are hospitalized. They're aggressively treated in hospital. I don't know actually the information on long-term outcomes of Miss C. My understanding is it's quite good, that children recover and are fine, but I don't know if they're more at risk for long COVID or other complications from COVID afterwards. So that one I'd have to look up for you.
Okay. And we had some questions about myocarditis as well, in teens, and what are the risks of myocarditis from catching COVID and versus getting the vaccine?
Yeah, so for all comers, the risk of getting myocarditis is higher from COVID than from the vaccine. So that's the risk is actually relatively small in both groups, but still the risk is quite a few times higher from COVID than from the vaccine. The really interesting thing, I found a article in a cardiology journal that was just published in February, and that the rate in teenage boys is about the same, the rate with COVID and the rate with vaccine. However, the vaccine prevents MIS-C, the vaccine prevents COVID and hospitalization and death from COVID. So still, if you're comparing apples to apples, if the rate is the same, you also get all these other protections from the vaccine. But for absolutely everyone else, the rates are far less for the vaccine. I did jot down the numbers here. The case, it was overall from immunization, it was like 3 in 1 million vaccines, a rate of myocarditis. I think the reason why we hear and see about it is just because we have this mass vaccination happening and everybody being vaccinated all at the same time, which we never do and haven't done with any other vaccines, the whole population for all ages all at once. So we were seeing and hearing it, but in actual numbers, 3 in a million. But for teenage boys, it was up around 100 in a million. So it's a lot, like, you know, when you hear how many times higher, it sounds massive, but it's still a massive change of a tiny little number.
And if someone does get myocarditis after a COVID infection or vaccine, what should they do? How is it found? And is there screening, and what's the treatment?
Yeah. So generally there's no screening, but people are tested based on symptoms. And most of the time people recover without any treatment at all, actually. So the majority of cases of myocarditis, especially from vaccine, I don't know that there have been any cases that were significant or prolonged. But with infection, there could be a longer case of heart issues. And often if you have myocarditis, it may not be in isolation with COVID. So you may have other organs that are being affected at the same time. So it may be more severe. And it is treated generally with, though mostly observation, for the most part, just maintaining and taking care of people as they recover from it. There isn't excellent treatment for the myocarditis itself.
Mm-hmm. And is there any sort of recommendation of a pause before getting back to physical activity after myocarditis?
And myocarditis, and I would also say COVID in general, especially with the data coming from long COVID, there are more and more experts suggesting that you should not push immediately back to high levels of exertion. That you should definitely be going, like if you're feeling short of breath or weaker or tired, you should actually be dialing down and not pushing through. And I know from the long COVID clinic at St. Paul's, that's actually one of their biggest messages. They had a whole bunch of elite athletes that came through their clinic, and they found that the majority of them were trying to push right back to their training schedules. And those folks are taking much longer to get better than people who rested. This is actually coming out too in the fibromyalgia literature, chronic fatigue syndrome, myalgic encephalopathy. There used to be this push to improve your exercise tolerance, and actually now there's a lot of studies showing that's actually doing some harm. So there may be some similarities here. I don't know that anybody understands all the science behind it, but it does not seem to be a good time or a good place to be pushing yourself after COVID illness, and in particular after myocarditis. You should probably be listening to your body, waiting till you're ready, and then getting back to activity.
That makes sense, to give your body a chance to rest.
Yeah. Yeah. And so I do have an update here, 28 confirmed cases of MIS-C in BC since January 2020. Thank you, Lynn.
We just have a few more questions. I understand some people might need to sign off as it's 8:30. Thank you. If anybody does have to sign off, I just want to say thank you to everybody who's joined us tonight. And hopefully you can stay for just a few more questions. I just had a question sent to me. What can we do? I think, why don't we answer that one at the end?
Sure.
It's a really good question.
It's a good question. Yeah. It's an important one.
It's a very good question. First, we were talking about how do we support kids who are feeling stressed during the pandemic. I know that this has been a really different time and a difficult time for everyone. And kids are, they're definitely feeling it.
Yeah, everybody's feeling it. And I think two things, before we can really even talk to kids, we have to work on regulating our own emotions around it. So really, whatever it takes for ourselves to try to reduce our own stress. Sometimes I don't even like saying stress and anxiety, because it sounds like we're just blowing things out of proportion. We're talking about really important things that are disproportionately affecting people who are already oppressed, reducing access to school for kids and families that are already dealing with disabilities and health issues and economic issues. Like, these are things to be stressed about. If you're going to be stressed about anything, the way the pandemic has essentially impacted our society is probably one of the things, but getting stuck there is really not helpful. I think it is important then to ask ourselves essentially that question, like, what can we do, and try to figure out in what ways we do have agency. What are the things that I can do for me, for my family, my workplace, my classroom, my situation, and trying to focus on those things as best we can. I think with kids, this is my personal take. You can take it or leave it. I'm not a pediatrician, but I think deep listening is critically important. I think we need to ask kids about their feelings about it. I think we need to help kids to give names to their emotions. I think we need to encourage children to recognize the way they feel stress in their bodies. How does that show up, to make that mind-body connection? Because those are really important cues for us to use to help us to identify emotions and how to process them and work our way through emotions. I'm a pretty big believer that there are a lot of ways that we can learn to process emotions so that we don't get stuck in them. I read a great analogy that emotions, if you think of them as a tunnel, there are things that you can do to come through the emotion to the other side, and then there are things that you do that you just get stuck in the tunnel. So to get through, we can teach kids to do things like breathing exercises, or recognize the stress and the things that alleviate the stress or the emotions, like exercise or singing or playing or art. Some kids are maybe cognitive, and some reframing is helpful. But for a lot of kids, actually, the physical behavioral ways of working through stress, shaking, dancing, these things actually work really well, probably for all of us, but especially for children. And it's sometimes easy as adults to get stuck on cognitive things, trying to think it differently or think a different way, which maybe because it works for us, but maybe not so great for kids. So teaching them some other strategies to process emotions so that they can work through them and not be stuck in them. And then the last thing I would say is being honest with them. You want to speak at their level in a way they understand, but sugarcoating things or gaslighting them, they know. Like Jen said at the beginning, the kids are smart. They get it. They know. And all you do is make them distrust adults if you tell them things that aren't true. You also tell them bad feelings are not okay. We don't talk about those here. We don't have them here. We pretend everything is fine. This toxic positivity. These are not good life lessons. We need to make it safe for kids to have hard feelings, difficult feelings, to process them, to talk about them, and to respect that they are way smarter than we give them credit for. And probably if we take our cues from them, we'll be doing a better job.
Yeah, it feels like they understand so much more than sometimes we give them credit for. The way I've seen, some kids take to masking to protect people they love so quickly, because that's just this is just what we do.
It's what you do.
People,
they can't imagine you wouldn't, right?
Exactly.
Like, why wouldn't you? Yeah.
And our last question, although we can tie in what can we do with the number of us here, what also is, what concrete action should schools take to lower risk of COVID spread, and how can we make that happen?
Well, I think all the things that we've talked about, I mean, rates are high in the community, so we should all be wearing masks when we're indoor in public spaces. And I think schools, that would be critically important place we should be masking. And then when you can't be wearing a mask, we should be limiting that as small as possible, eating outdoors, if possible. With some small communities, kids can even get home to eat. And we should be definitely trying to create the conditions so that it's possible for kids to do that. Ventilation, filtration, opening windows, HEPA filters, Corsi Rosenthal boxes, anything to clean the air should be happening as well in schools. I think educating folks on the airborne nature of the virus, the role of vaccines, the need for vaccines, how they reduce transmission and not just hospitalization and death, and that reducing transmission is important for all of us. I really think this schools are probably one of the most important places to be ensuring that we're not making decisions just for our own individual, that it has to be about the collective. We're all there all day together all year. And so we need to be making choices that are best for the collective. And so we really need to be thinking about those who are made most vulnerable. And we should be working to reduce their risk, because when we reduce their risk, we reduce everybody's risk. As I heard a parent advocate say, some kids have had to sacrifice their education for their health, or sacrifice their health for their education. This should never happen. They should be able to have both their health and their education. And we should be making accessible schools so that that's possible for everyone.
100%. Yeah, I've always referred to our school as our community. These are the people that, I'm entrusting to take care of my kids, and, friends, the parents, would pick up my kids. And so we've worked together for so many years. It seems like the perfect time to just continue to work together. Karen, I saw that you put teens talking to each other and deciding to mask up, confirming it with friends is so amazing. Again, that's just part of that community and working together and promoting it with each other. If anybody else had any other questions, that's kind of what we had. I want to take a moment and again just thank Dr. Hardie and Jen Heighton for joining us and sharing their experience and their knowledge. And thank you to DPAC for allowing this forum to happen, giving us the space.
Jennifer, did you have anything you wanted to add?
I'd like to add in terms of what can we do, question, what can we do? I would say write to your MLAs, write to your trustees, write to anyone who can advocate on your behalf and advocate yourself. There is a certain power in doing something and not letting these things happen to us. There is a certain amount of empowerment that comes with that. And so firing off that letter to, Dr. Henry, or to Adrian Dix or Jennifer Whiteside, who is our education minister. She actually has quite a lot of power should she decide to use it. So getting to those people in power and just letting them know what you think, tell them your personal story, what you believe in, why you think it's important. And all their emails are listed on government websites. Same thing with trustees and anyone else who, could be a positive influence for your kid. So again, go ahead.
I was going to say, I should add as well, as seeing as you and I work together on Safe Schools Coalition, that has been a tool that has allowed a lot of parents and educators to work together to be heard. And one of the things that I've found is a few things that I've learned in advocating is that your letter to education stakeholders doesn't have to be long. It doesn't have to be pages long. If it's personal and says how you feel and what you want, that's great. That's amazing. And it makes a difference. Speaking out makes a huge difference. And the other thing is that going to websites like PoP BC and Safe Schools Coalition and others, use the information that is there. You know, nobody's going to come after you for copying. Use the tools that are out there to speak out and say what you want for yourself and for your kids.
And pay attention to trustees who you are able to see that they are being proactive and who isn't, because often people vote for trustees according to alphabetical order or according to party, and you don't necessarily get the people that are engaged when you do that. They may want to become someone in city council eventually, and this is their stepping stone, for example. So paying attention to trustees is very important.
And on that note, there is a civic election coming up in October of next year. Well, this year actually. So just in a few months. And this is going to be important for us to, you know, elect in ones that are going to be listening to what your concerns are. The other thing too that's been mentioned to me is for those who do suffer adverse effects, there are legal routes to take. And especially for those who are disabled or have a disabled child or immune compromised and are being negatively affected, there are human rights complaints that you could do. I've been told by a lawyer to just let people know that that is an option. And there's actually a letter that was written. I don't know if everyone's aware of it, but
I posted it at the top. I'll
yeah,
go and bring it down again.
The Human Rights Commissioner's letter that
Yeah.
came out today.
I'll find it and post it lower again.
Great, thanks, Karen.
But I do know that there are people mounting human rights complaints now. So that is definitely a possibility. DPAC, I believe DPAC always holds an all candidates meeting where we invite all the candidates. So if you have questions for them, when we know who is a candidate, pay attention to our website or to our Facebook and our Twitter, because we will definitely be advertising that for trustees. So I also want to thank you, Jennifer, and Kyenta and Dr. Hardie. This has been really informative. I have pages and pages of scrawl, trying to keep up and catch the little bits that make me think. Deeply appreciate the time you've taken tonight and all of the work that you've done, both with Protect Our Province and also with Safer Schools, and the other work that all of you have been involved in the last 2 years. I know it's all kind of on the side of your regular daytime job, so deep appreciation for that.